Hello, I'm Sven Gudmund Hindraker, Professor at Center for International Health at University of Bergen. In this lecture, I will tell you about how to analyze the treatment outcomes of tuberculosis patients. It's called Cohort Analysis, as we report all possible outcomes of the cohort registered in a time period. After this lecture, you should be able to report treatment outcomes of tuberculosis patients in a register, to list the standard treatment outcomes, and to discuss common pitfalls. Who is enrolled and counted in a cohort analysis? Usually, in tuberculosis programs, the reports are done every quarter and summing it up every calendar year. Chest symptomatics for a laboratory examination will be registered only in the laboratory register. Those who turn out to be bacteriologically positive, whether microscopy or culture, are proven contagious and should ideally be in the tuberculosis register, even if treatment is not initiated. But often, in actual practice, only those who start treatment are recorded in the register. All patients initiated on treatments, whether proven bacteriologically positive or not, must be recorded in the tuberculosis register. A cohort must be defined by a registration date, not actual treatment initiation. So, every patient who is registered in the quarter you're analyzing is enrolled into the cohort. The cohort completes the treatment after 6 months, but there are always some patients who had extended treatment. Hence, outcomes are given for the quarter enrolled or registered a year before. Hence, when reporting quarter case finding, usually the most recently completed quarter is given, but the outcomes are reported for patients registered a year before. At registration, the patients get an ID number from the register and is given a treatment card, and all baseline information is recorded, like age and sex and address and results from a laboratory and type of tuberculosis. Follow-up is done by health workers, and every visit is recorded in the patient card and in the register. In epidemiology, the usual cohort outcomes are given in numbers per person years of follow-up. The duration of follow-up is the same for all patients in tuberculosis cohorts, and this simplifies the analysis. During treatments, patients should be supported, and if lost to follow-up, they should be traced and returned to treatment. Cohort analysis must account for all who were registered during the time in question. What can happen during treatment? These are the standard treatment outcomes of tuberculosis patients. There are 6 mutually exclusive outcomes. Cured represents those positive in laboratory examination. They completed with negative examination in the end. Completed represents those who completed well but have no final examination. Died represents those who died during treatment, whatever the reason. Failure represents those who after treatment still have bacteria detected in their sputum. Lost to follow-up represents lost patients who do not collect drugs for 2 months or more. Transfer out represents those who move and are referred to another place. In addition, in order to do correct cohort analysis, we add to these 6 outcomes an extra category for not evaluated. The patients who are new and those who are treated before have different treatment regimens and are analyzed separately. New tuberculosis patients are further categorized based on the degree of infectiousness. Extrapulmonary tuberculosis have lowest potential. Then middle potential is pulmonary tuberculosis with negative laboratory test, and most infectious are the bacteriologically positive patients, who are always reported separately. Patients who get retreatments may have different reasons, but all get the same treatment. Results are indicated as successful treatment, which includes those who completed and those who were cured. Poor outcomes depends on whose perspective it is. For a patient, a bad outcome is failure or death. For a program, bad outcome is failing to remove the source, that is, failures, lost to follow-up, and not evaluated, whereas dead patients are not a source of infection anymore. Here are some examples from cohort analysis of treatment patients treated in 2013. India has a good success rate, but a relatively high proportion of loss to follow-up. It could be related to a huge private sector less eager to the frequent reporting. Tanzania in Africa has a relatively high rate of patients dying, probably due to many patients co-infected with HIV. Norway has very few cases, but relatively high proportion of not evaluated. From a public health perspective, it is important to know the situation in the society. Therefore, cases should not be excluded from the cohort analysis. Often, clinical studies with follow-up restrict the enrollment in order to make comparisons for hypothesis testing. For public health, it is necessary to account for all sources of tuberculosis infection and include all identified patients in the register. There are global targets for tuberculosis control activities. Modeling calculations have shown how many you must find and cure in order to impact on prevalence. If we are able to detect at least 70% of the most contagious patients in the world and successfully treat at least 85% of them, it should have a clear effect on the epidemic. Targets may spur the programs to better achievements and are often linked to performance-based benefits. They may, however, have other effects. The global targets have some weaknesses. Target 1, 70% case detection rate is the aim, and this indicator has not a known denominator. It is only estimated from other data. This can lead to praising the poor performing and blaming the well performing. Target 2, 85% success rate of patients detected. For public health action, this indicator is not useful and may blame for things that cannot be controlled. But using attractive targets is very useful in public relations, which is also very important in tuberculosis control. Let me give you an example from Malawi in 2001 and compare with Tanzania in the 1980s. We categorize into patients who can transmit and not. The green treatment success was higher in Tanzania than in Malawi. However, the blue deaths by not transmitters and proportion non-transmitters were actually higher in Malawi. Patients with red uncertain outcome is more relevant to the program. That is, more risk in Tanzania in the 1980s than in Malawi in 2001. In order to ensure public health, there must be a mandatory notification system for tuberculosis. Some elements are as follows. All clinicians must report every case of tuberculosis, even if not quite sure about the diagnosis. Laboratories must report each confirmed case of tuberculosis. There needs to be a system to link the laboratory with the clinicians. Bacteriologically confirmed cases must be reported separately from the others.